Good morning. I'm Bivani Rajendran from Hospital Raja Permaisuri Bainon Ipoh. Will be presenting a case study on amniotic fluid embolism from my clinical internship 2. Okay. This slide presentation contains first introduction of amniotic fluid embolism, introduction to patient, case sequence, laboratory investigation, massive transfusion protocol, conclusion, and reference. Okay. First of all, what is amniotic fluid embolism? Amniotic fluid embolism is a life-threatening obstruction emergency. It happened due to sudden gash of amniotic fluid, fetal cell, hair, and amniotic debris entering the maternal circulation. Amniotic fluid embolism occurs in 7.7 per 100,000 births, and the estimated mortality death rate is 70 to 90%. As is shown in this diagram, a defect in membrane of placenta can allow amniotic fluid to enter maternal bloodstream and cause reaction to the mother. Okay, the sign and symptoms. First is sudden collapse due to profound hypotension, hypoxemia, and DIC, disinterminated intravascular coagulation. Amniotic fluid embolism is most likely to occur during delivery or in the intermediate postpartum period. In our case study, the sign and symptom that is very prominent is dye-insulated intravascular coagulation, and the reaction took place after a postpartum period. Okay, introduction to patient. Madam S is a 32 years old Malay female, and she delivered her first child in 2015 and had a miscarriage on 2016. On 17 May of 2018, she delivered a second baby on 35th weeks 6 days with emergency lower cesarean section. After a post-EMLS, Madam S was noted with DI intravascular coagulation with intermittent anatomy. She was done a subtotal hysterectomy with abdominal packing. Case sequence. First, Madam S was admitted at her 35th week and 6 days of gestation in a labor room, Hospital Raja Permaisuri Bainon. Oxytocin was administered during labor, which developed quickly with dilated going from 3 cm to 9 cm in 2 hours. At that time, a sudden fetal bradycardia was detected and prominent extraction of the soon-to-be neonatal was performed with the aid of an extraction vacuum. The newborn was a female weighing 3.1 kg and was transferred to an ICU, and Madam S was transferred to first maternity ward. After a few hours after her delivery, Madam S developed massive vaginal bleeding, and a physical examination revealed a soft uterus and coagulated blood in her vagina. Her blood pressure was dropped to 80/48 with a pulse rate of 120 per minute and a respiratory rate 20 per minute. Her body temperature is 37.7 degrees with no respiratory distress. Immediate ultrasound imaging and CT scan was done, and it revealed a large retrovascular hematoma. They were present of severe bleeding from uterus, vagina bleeding with consequent hypovolemic shock. Due to this, immediate massive transfusion protocol (MTP) was activated, and during the hysterectomy, a total of 14 units of PEG cell, 12 units of FFP, and 12 units of cryo unit and 12 units of platelet was transfused. Madam S received a total abdominal hysterectomy because of persistent and uncoagulated bleeding. Her uterus and right fallopian tube were removed. The vital sign and laboratory data became stable after hysterectomy, and she was transfused to ICU for observation and was after a fully recovered, she was discharged home. Her laboratory investigation during her amniotic fluid embolism reaction was her hemoglobin, hematocrit, and total red blood cell dropped from the normal range. This is because of a massive blood transfusion loss. It could lead to anemia for the patient. And the coagulation report shows prothrombin time increased to 32.9 cm and activated partial prothrombin time, thromboplastin time increased to 50.7 seconds. And the biochemistry result shows most of her liver function test parameter, total protein albumin, ALP, ALT, and AST. It shows a decrease from the normal range. Even her sodium, potassium, and calcium in phosphate shows below the normal range. Okay. Laboratory investigation. Histopathology examination. From the hysterectomy, a section of uterus, right ovarian, and fallopian tube was sent to histopathology examination. Interpretation of the result was uterus Features are in gravitic uterus and presence of chronic villi suggestive of retained product of constipation. There was a presence of chronic villi suggestive of retained product of constipation in the uterus, and there is no evidence of malignancy in right ovary and fallopian tube. Massive transfusion protocol. As a medical lab technologist, we play a role in this case study by supplying a blood product to the patients. What is a MTP? MTP is a massive transfusion protocol that is activated by a clinician in response to a patient that is experiencing massive bleeding. The responsible clinician activates the MTP either by phone or any other mechanism. Once a patient is in the protocol, the blood bank is able to ensure rapid and timely availability of blood component to the facility requisition. The need for MTP can be encountered in either surgical or medical emergency where life-threatening hemorrhage is confronted. As for this case, MTP is very important as the patient's BP and patient is having a massive blood loss. This massive transfusion could help in the coagulation factor at the early stage of amniotic fluid embolism. Okay. This is the flowchart of massive transfusion protocol that is practiced in hospital HRPP blood bank. Once the MO or houseman called to activate the MTP, the MLT should be prepared with first package of MTP package, that is 4 units of PEG cell, 4 units of platelet, 4 units of cryoprecipitate and 4 units of FFP. This should be given in 15 minutes time. Once the first cycle was taken, the MLT will continuously prepare the second cycle with the same package, and it continues until the MO start call to stop the transfusion. Conclusion. In conclusion, as experienced in the case, amniotic fluid embolism is rare but is rapidly developing fatal disease. Amniotic fluid embolism disease is hard to diagnose in its onset and the treatment is still difficult. Therefore, clinicians should suspect AFE when proposed postpartum hemorrhage develop with coagulation and cardiopulmonary compromise. The initial management of amniotic fluid embolism relies on early diagnosis and prominent administration of blood product, including coagulation factor and platelet, which are essential for patient's recovery. Okay, thank you.